Well, good afternoon, everyone. So exciting to see a full house, and we're very, very excited to discuss today how a new generation of coronary sinus reducer can expand treatment options for patients with CMD. As somebody who's been working in this field for a long time, it's really gratifying to see it take off and have so much interest, and the ability to treat is something that I think has really spurred a lot of the interest that was latent for so many years. So we have an unbelievable panel today. Joining me as moderator is William Wins. Also, we have Bernard de Bruyne from Aalst, Francesco Giannini from Barcelona, Tim van der Hoof from Utrecht, Alex Lansky from Yale, and I'm Bruce Samuels from Cedars-Sinai Medical Center in Los Angeles. And the objectives for this session are really to understand what reducer therapy mechanism of action is. This is a very important topic. To understand what Vahadicor is doing to build clinical evidence for the use of a coronary sinus reducer in treating microvascular dysfunction, to understand how A-FLUX's design is building upon the available literature, and to recognize, of course, the importance of just focusing and understanding and diagnosing CMD in the general population. So with that, we have a really packed agenda in a very short period of time, but we wanted to just start with a show of hands with the poll so we can sort of understand where our audience is coming from. I know there's a mixture probably of physicians and non-physicians in the audience, but for the physicians who are here, we'd like to know how many of you are not performing any CMD testing right now? Can you just raise your hands if you're a physician and are not doing any CMD testing at all? Great. How about those of you who are doing CMD but less than 20 per year? All right. How about those between 20 and 80 per year? Wonderful. And how about more than 80 per year? All right. So we really have a very even split. So that's good for us to know as we start our journey here in educating about this wonderful and important field. So we're going to start with Professor de Bruyne, who's going to speak to us about diagnosing a coronary microvascular dysfunction patient.
Thank you, Bruce. And while Bernard is setting up the slides, so feel free to go, please, to the mics and ask questions wherever you have some, and also use the app. We have Dr. Samit Shah from Yale, who's actually online and can address them.
Thank you, Bruce and William, for asking me to set the stage, so to speak. And speaking of definition of coronary microvascular disease, or CMD, I think we can all agree by saying that coronary microvascular disease refers to a condition affecting the microvasculature, specifically the microvessels, leading to an impaired blood flow to the myocardium. But actually, it all boils down to an abnormally high microvascular resistance. That is what you have to keep in mind. Microvascular resistance. That's where the problem is. Now, the prevalence of CMD has been reported to be high. Actually, it is highly variable according to the definitions, according to the method used to define CMD. And let's go to a patient. And let's be very practical. And let's look at this patient, 60-year-old female, couple of risk factors. Typical, but also quite atypical angina, chest pain. She was already seen in several hospitals, in several departments, by several colleagues. She was called to have a normal SPECT. And then she was sent to the Anoka clinic in our hospital, where Dr. Brouwers, seated in the first row there, thank you, Sophie, took again the story of this patient, again the anamnesis. So it's a specific entity where a non-invasive cardiologist interrogates the patient, order the CT, order non-invasive stress test to see whether or not they are positive. This is a CT of these patients, but I would like to state that it is at this outpatient clinic that the decision is taken to send the patient to the cathlab. And in the cathlab, invasive coronary function tests are performed, and we try to be very rigorous with these testing. It all starts with baseline testing, LV angiogram, coronary angiograms, 12-lead ECG. The second step is to investigate the coronary circulation and to make absolutely sure there is no spastic component. This is, of course, not the topic of today, but I would really like to encourage you to do this. This is very rewarding, and this is very actionable also. And finally, if this is negative, and by the way, also if it is positive, we go to the last step of the coronary functional testing, namely the CMD, the interrogation of the microcirculatory function. And in our hospital, at least, we systematically do bolus and continuous coronary thermodilution. Now, this is the coronary angiogram of this patient. We have seen the CT. The CT was strictly normal. The angiogram, invasive angiogram, is also very reassuring, maybe a couple of irregularities in the proximal LED. And this is bolus thermodilution. Do you guys recognize this tracing, or are you familiar with these tracings? So just in a nutshell, you have the pressures here. 3 pressure tracings at rest and 3 pressure during hyperemia. And then underneath the slide, you have 2 times 3 thermodilution tracings. The first in blue at rest, and then on the left side in yellow during hyperemia. And actually what is calculated by the software is the mean transit time, which is actually a surrogate of flow velocity. And from this mean transit time, coronary flow velocity reserve is derived, and the index of microvascular resistance is derived and calculated. In this patient, coronary flow reserve by bolus thermodilution was 2.2, abnormal, IMR 37, too high. So this is already a hint towards the presence of coronary microvascular disease. And then we confirm that in this patient with what we call continuous coronary thermodilution. This has been introduced a couple of years ago. And to make it very, very simple, just remember that with continuous thermodilution, we are no longer measuring indices or approximation. No, we are measuring flow and resistance in absolute terms. So what you see here, at rest, we have 77 milliliter per minute. During hyperemia, 160 milliliter per minute. During maximal hyperemia, the resistance of the microcirculation is 551. To make a long story short, these are abnormal figures. This patient has definitely coronary microcirculatory disorders, microcirculatory disease. And I insist on the certainty of this diagnosis, certainty which relies definitely on continuous thermodilution, which provides really accurate and absolute assessment of CFR, MRR, and I would say the cherry of the cake is this absolute value of microvascular resistance. This being said, there is definitely a need in this patient for new therapeutic option, and I think I will leave the word to Francesco, but probably there are questions before.
Thank you, Bernard. This was crystal clear. Please feel free to ask questions. You go to the mic. The session is recorded, so speak loud. Introduce yourself.
If there are no questions, I can ask a question. Bernard, you showed us a beautiful case. This was a patient who was identified by an outpatient clinic and then came to the cath lab as the idea that this patient will have microvascular disease, already had diagnostic imaging. What about patients who come unexpected, where we expect to see a coronary stenosis and perhaps are an inpatient? Do we do this ad hoc as well, or should only be done as a scheduled case?
Well, strictly speaking, it is of course technically possible to do everything ad hoc. But I would strongly advise, if you are beginners in this field and if you intend to develop an ANOCA clinic and to investigate these patients seriously, to plan them electively. They have to be triaged, they have to be selected by a non-invasive cardiologist who have to decide whether or not the patient has to go to the cath lab, and then to plan everything ahead, including acetylcholine, by the way, and then to go to the coronary microvascular function testing afterwards. But, of course, when you are used to it, you can do that ad hoc. That's, of course, no problem.
Thank you. Since the room is packed, you may think it's difficult to go to the mic, so we have our hostess there. Just raise your hand and ask your question. Yeah.
Right. Well, one more then. We have a question.
There is one question there.
Hi, my name is Razan. I have a question. Why did you suspect they could be a microvascular? Why did you go there? Usually if we do a cardiac cath and all of the studies, we'll say, okay, there's nothing wrong. This is just It's
yeah.
non-cardiac, you know?
Yeah. That's a very good question, and that is exactly the way these patients were treated up to a couple of years ago. There is nothing wrong with you. Everything is in between the ears. Go home. There is nothing wrong. Actually, we have to be, let's say, to be more complete in our diagnosis as soon as the anamnesis, and taking the anamnesis in this patient is key, absolutely key, is very suspicious, meaning typical chest pain, exercise, but also at rest. Sometimes there are atypical aspects, and also that they come back and back and back and again. That's one of the major factors. Having the diagnosis made invasively and excluding the diagnosis, ruling out the diagnosis, is almost, and maybe even more important than making a positive diagnosis of coronary microvascular disease.
Thank you. Is there a non-invasive way of finding this out?
Well, if you ask that in an audience of non-invasive cardiologists, they will all say yes. There is PET, there is CMR, thank you. There are many other ways, probably, that I ignore, but I can tell you there is only one accurate and precise, both are important, accurate and precise way of establishing that the resistances of the microcirculation are abnormal, that is in the catheterization laboratory. And even in the catheterization laboratory, you have to do it properly.
Wonderful. Thank you so much, Bernard. Appreciate it. I apologize we couldn't get to every question, but we have a tight schedule, and we wanted to bring up Francesco to talk about diagnosing, coronary sinus reducer microvascular dysfunction patient case. Really some wonderful content here. So we want to give Francesco his full allotment of time. Thank you, Francesco.
So, good afternoon, everybody. Many thanks, Bruce, for the kind introduction. So my clinical case is about a 67-year-old lady with hypertension and hyperlipidemia well controlled with medications. She has a long clinical history of chronic angina pectoris with Canadian class score class 2 to 3 and reduced exercise tolerance despite treatment with beta blockers and ranolazine. She does not tolerate long-acting nitrates and calcium antagonists because of headache. She already had an exercise tolerance test that was positive for ischemic ECG changes, and she already underwent several times coronary angiographies, always showing no epicardial coronary artery disease. In the last few months, she had a worsening of angina symptoms. At that time, for minimal exertion, for this reason, a new hospitalization was scheduled to repeat the coronary angiography. These were the medications. The echo showed a normal systolic LV and RV function, no valvulopathies. The Holter ECG showed a mean heart rate around 56 beats per minute without any arrhythmia. This was the coronary angiography, so once again showing no epicardial coronary artery disease in both the right and the left system. Then we decide to perform a full coronary physiology evaluation with a pressure wire placed distal into the left anterior descending artery. The adenosine fractional flow reserve was 0.91. The acetylcholine test was negative for vasospasm, so we decided to perform a bolus thermodilution revealing a coronary flow reserve of 2.1 and IMR of 19. So to summarize, we have a patient with severe angina symptoms despite maximally tolerated medical therapy. We have absence of epicardial coronary artery disease with also a negative fractional flow reserve, and we have clear evidence of myocardial ischemia with a positive exercise tolerance test, but also a coronary flow reserve that is below 2.5. So we are facing with a patient with coronary microvascular dysfunction. So which therapeutic option we can consider for this patient? She has already an healthy lifestyle. She's taking 2 antianginals. We cannot introduce other antianginals because of the side effect. We cannot increase the dosage of beta blocker because the heart rate is relatively low. There was a discussion of the case with the local art team and with the patient, and finally this patient was considered a good candidate for the control narrowing of the coronary sinus with the implantation of the A-FLUX reducer. The A-FLUX coronary sinus reducer is a novel self-expandable reducer made in ethanol with 4 sizes available, 9, 11, 13, and 15 millimeter. It is fully recapturable up until 50% of the deployment and can be repositioned after the recapture. It has a small tip to facilitate the retrieval of the delivery system. It has denser mesh to have much more impact on the coronary sinus flow and to provide immediate symptom relief and potentially reducing the number of non-responders. Very briefly, the procedure is performed through the jugular vein. We engage the coronary sinus. We perform the coronary sinus angiography. We identify the right site of implantation. We select the proper size of the device, and then the delivery system is advanced over a 0.35 wire up to where we are supposed to implant the device. Then the device is deployed by unsheathing the system, and you can see here the full deployment of the device, appreciating the stability of the device during the deployment. And then after retrieving the delivery system, this was the final angiography showing a good result in this illustrative case. But coming back to Our Lady, you can see here the coronary sinus angiography in both LAO and RAO 30 degrees. We are facing with a relatively small anatomy that is quite common in women. This was also confirmed by the coronary sinus QCA. Based on the measurement we have taken, we selected the smallest size of the device, the 9 millimeter device, and we identify as the right site of implantation the mid portion of the coronary sinus that was large enough to accommodate a 9 millimeter device. Here you can see the deployment of the device. So here we are at the beginning of the deployment. We have already deployed the distal half of the device. So if we don't like the position, we can still recapture the device, we can adjust the position, and we can release it again. And what we look at in this phase is the degree of compression of the device. So having in mind which is the natural shape of the scaffold when it's fully expanded, what we need to achieve here is a 20 to 50% of oversizing. If we have this kind of oversizing, then we know that we are properly anchored the device, we know that we are overstretching the vessel wall, and that's important to promote the growth of new tissue to get the effective stenosis. So if we are happy, we can keep with the deployment on the device, and this was the full deployment in this patient. This was the final angiography showing a good final result. The procedure took less than 30 minutes. Few milliliters of contrast have been required, and the patient was discharged the day after the procedure in dual antiplatter therapy with cardioaspirin plus clopidogrel. At 1 month's follow-up, there was an improvement of angina symptoms from Canadian class score 3 to Canadian class score 1. This benefit was maintained over the time at 3 and 6 months follow-up. Accordingly, there was also an improvement of quality of life evaluated with the Seattle Angina Questionnaire, and you can see also the improvement of both items, the angina frequency and the treatment satisfaction. At 3 months follow-up, the patient underwent another full coronary physiology evaluation, revealing an improvement of coronary flow reserve from 2.1 to 2.7, a mild reduction of IMR from 19 to 16. At 6 months follow-up, the patient underwent a cardiac CT showing the patency of the device, no thrombus, no contrast behind the struts of the device, confirming the good function of the reducer. So in conclusion, the A-FLUX is a next generation coronary sinus reducer, as a design to provide a direct modification of the flow soon after the implantation, and theoretically to provide symptoms relief soon after the implantation. The procedure appears to be safe, simple. In our case, was definitely effective. Of course, we need much more data, and this is why the early feasibility study called SERRA-I is already planned, and we will discuss later about that. I want just to thank Mario Stomaniak, that is here on the second row, because I had the privilege to work with him to this procedure that was performed in Barca 1 year ago, and many thanks for your attention.
Super. We have time for questions? Yeah. Wait until you have the mic.
Thank you very much. My name is Alex, UK. what is the suspected mechanism through which this patient improved her symptoms?
Okay, I think this is probably one of the key questions of this session. There is a presentation dedicated to that. We will discuss again about that.
Right after. Good. We did not pay him to ask that question, but it's coming up. Another question?
Yeah, just Basti from Switzerland. Just a question about the antiplatelet therapy. How long do you do it? And you don't worry about having thrombosis because there won't be covering but the cells on the venal, it's a venous and with low pressure.
Okay, so the antithrombotic regimen that we are utilizing now is DAPT for 6 months. And this comes from the COSIRA trial that was the first trial with the narrow coronary sinus therapy with a different device. We didn't get in the preclinical study no cases of thrombosis of the device. And we have already treated the 12 patients without any adverse event, with most of the patients already concluding the 1-year follow-up. We have some patients in which cardiac CT was performed. We never have seen thrombus in the device, and we have clear data showing the full endothelialization of the device a few weeks after the deployment. So I think the thrombosis should not be considered concern, but of course we will have data also from the early feasibility study.
Francesco, a colleague online is asking about location. Where do you release the device? And of course, I'll add my part to that question. Those of us who are senior enough to know and remember the wall stand know that at the moment of deployment, it tends to jump. I mean, how carefully can you locate it, the deployment?
Okay, so ideally we should try to implant the device very proximal, because if we implant the device in the proximal segment of the coronary sinus, we will involve in the therapy much more ischemic myocardium. If we implant the device distal to the origin of the side branch, we will miss in the territory in the treatment the territory that is drained by this side branch. So we have to try to be proximal, but of course we need to balance the will to try to be more effective with the safety of the procedure. Sometimes it's better not to be very, very proximal, otherwise we risk to have some migration if we come back even for a few millimeters. And of course, what is crucial is to see when we deploy the device how the distal half of the device is expanded. If there is some degree of under-expansion, we are confident to say that we are properly anchored and we are overstretching the vessel wall. So this should guide us before releasing completely the device.
And the repositioning capability allows you to adjust the intended deployment site based on that.
Definitely, we can, when we recapture the device, we can adjust the position. If we have concern about the size, we can retrieve the device, we can change the size. This is definitely an advantage.
Questions from the floor? Any of our panel members has a question? Bernard?
Well, you have controlled these patients after 3 months, and you have used the pressure wire to measure again bolus thermal dilution. You did not put the pressure wire across the device to see whether there was at least a pressure gradient?
This is a question that I would like to ask to you, because here we are facing with the retrograde flow in a coronary sinus. I mean, I don't know even how to interpret the data.
Oh. Well, I think we'll see in the next presentation on the mechanism of action that the changes in pressure are quite small, but meaningful.
Yeah, what we know is that when we implant this device, we generate a gradient through the device. This device generates a gradient of few millimeters, but is enough to increase the cardiac venous pressure and increase the coronary flow reserve at the end.
A question here?
Actually, I should answer this question because I was doing this for follow-up for microvascular testing. So indeed, we didn't do it via the coronary sinus, but what I can say is that indeed the CT at 6 months showed that the device is patent, yes, without any device fracture. and the follow-up was done at 3 months already, and now we have 10 months of follow-up. We're in contact with this woman, and this relief is sustained.
Fantastic.
Thank you.
Tim, you have a question? Okay, I do. You made a comment several times about the more rapid reduction in flow and the more potential rapid symptomatic improvement. Can you say something mechanistically about the neck or the shape of the device that might lend that some objective reason why that might happen?
What at the end it's important to create a gradient is the endothelization of the device, of course. But the device per se generates a gradient. This is true regardless of the device we are utilizing. Here we have a device with denser mesh, so this should have a higher impact on the coronary sinus flow. And we know this is crucial actually to have the efficacy and to have the improvement of symptoms.
What has been the experience so far in terms of the improvement in symptoms and how quickly that happens?
We have treated 12 patients until now, with the exception of one patient. We had an improvement of angina symptoms in all the patients, and this tends to be maintained over the time. So these are the data that we have. These are not big numbers, but we know in this niche is important also to try to understand, even if you have, especially when you are the initial experience, also from a few patients. So.
Tim? You have
a question? Okay.
Okay. Anyone else? All right. Yeah, one more question up here, please.
Thank you very much for your interesting talk. When do you can stop medication of anti-anginal medication? Do you stop it after that, or it help you to reduce the medication? And after when?
I like this question because what I notice in my patients is that when you have a benefit in terms of angina symptoms relief, then is when you can stop some medication. Most of these patients live with the side effects that are caused by several drugs. So if you can stop, if you can discontinue one of these drugs, most of the time you have an improvement of quality of life related to the discontinuation of this drug. So this is something, I don't have a precise answer, but I would wait 6 months before discontinuing one of the drug, being ready to restart the drug in case I have recurrence of angina.
All right. Thanks very much, Francesco. Okay, and as promised, we're now going to give a very important talk on the mechanism of action. And there's really nobody better than Tim van de Hoof from Utrecht to educate us about this. Thank you, Tim.
Thank you, Bruce, for the kind introduction. So the aim of this talk is to go over what we consider the physiological evidence on how coronary sinus narrowing ultimately leads to an improvement in symptoms in these patients with coronary microvascular dysfunction. So what is really important to realize, and as alluded to by Professor De Bruin, the highest resistance to blood flow to the heart, and by that also the potential to regulate coronary blood flow, resides at the level of the coronary microcirculation. So in patients with coronary microvascular dysfunction, a high resistance to coronary blood flow or a pathologically increased resistance to coronary blood flow at the level of the microcirculation is considered the cause of persisting symptoms in these patients. So by inducing coronary sinus narrowing, by implanting a coronary sinus reducer, we get an increase in venous pressure, venous back pressure from the venous side of the heart. And this leads in turn to microvascular recruitment that we can measure by a decrease in the measured microvascular resistance and an improvement in coronary flow reserve, which ultimately leads to an improvement in symptoms in these patients. So these mechanisms were documented. One of the studies showing this was a study from Thomas Agori's group in Mainz, where in CMD patients, a sham-controlled balloon inflation in the coronary sinus was documented to lead to a significant decrease in microvascular resistance measured by the IMR. Further validation comes from an in silico model where narrowing of the coronary sinus led to a small increase in coronary sinus pressure of around 3 millimeters of mercury, which led to an increase in microvascular network diameter of 6%. This might seem small, but it's important to realize that this change in diameter is reflected in a much, much larger change in surface area in the microvasculature, which ultimately impacts myocardial perfusion. So further validation comes from the Mayo Clinic, where implantation of a coronary sinus reducer improved coronary flow reserve significantly in patients with coronary microvascular dysfunction, which was also tied to relief of symptoms. This improvement in coronary flow reserve is not irrelevant. It's actually highly relevant because, as we now recognize, coronary flow reserve represents truly a continuum of risk, where very low levels, lower levels of CFR predispose patients to adverse clinical outcomes, which also includes mortality. And this holds true for all diseases, particularly for patients with coronary microvascular dysfunction, as documented in this very interesting meta-analysis from the London group. So to reiterate this slide where we started with, as we understand now, narrowing of the coronary sinus increases back pressure. It elevates venous pressure in the coronary sinus, which subsequently leads to microvascular recruitment, which we can measure as a drop in microvascular resistance and improvement in coronary flow reserve, which ultimately improves patient symptoms. Thank you very much for your attention.
Beautiful, very clear, thanks. There must be some questions from the audience. We'd love to get some discussion going. Oh, you're too clear. How about anyone?
I just wonder, I mean, if you look at this from the outside, it seems that a 1 to 6% difference, is that going to translate into, how is the clinical impact, and what is the minimum change that is required to have an impact on symptoms?
I think that's an excellent question, Professor Wijns. I think there are several considerations that are really relevant, right? So an increase in pressure of 3 millimeters of mercury is very small. It's very small, so that leads to an increase in pressure in the coronary circulation. It distends the microcirculation, which leads to an increase in diameter, which is up to 6%. But it's very important to realize that this 6% diameter change relates to a massive increase in surface area. So I think as the surface of the microcirculation ultimately impacts myocardial perfusion, this small change the small change in diameter actually relates to a very large impact in myocardial perfusion.
Question here?
I have a question because the patients who develop right heart failure, they also, in these patients, the CVP increases. Can we see the same mechanism in the coronary flow reserve reaction to this situation, comparing to the reducer implantation?
That's an interesting observation, and what is important is that in all reducer studies until now, patients with an elevated right heart pressure were excluded from implantation of the device because the added pressure by implanting the device is not considered a mechanism of action in these patients.
Yeah. It is beneficial to develop the CVP in these patients in terms of coronary flow?
So there's no data on this. And also in the studies that we are performing up to date, patients with a right heart pressure or a right atrial pressure of above 50 millimeters of mercury, we do not implant the device.
Have another question?
Thank you. Ramza Tabla from Jordan. So I guess some of these patients will not improve in spite of a successful procedure. How do you explain the symptoms of these patients? You've ruled out coronary artery disease, you ruled out vasospasm, you did the procedure and the procedure is successful, and yet these patients continue to complain of angina. What is the explanation for their symptoms?
You want to take that, Tim?
I think that's an interesting question, and from this device in microvascular dysfunction, we need to learn more, right? Because the non-responders may be that there's an additional endotype of disease, or of ANOCA disease, that might impact also their symptoms. It might also be that the patient does not respond to the therapy, so that the microvascular, the impairment in microvascular perfusion has not been improved by the device. And the last part is, of course, a very interesting part of the research that we will be doing to identify which patients benefit most from this device. Is it truly patients that have structural microvascular dysfunction, or is functional microvascular dysfunction in patients with more endothelium-dependent problems in the coronary circulation? May they also benefit from the device? So that's things we still need to learn.
I would like to extend a little bit on your question. Why are there some patients who are non-responders? Well, first, of course, they might have something completely different, but the most likely reason is that they have been poorly identified at the diagnostic phase. In other words, we did not hit the wrong target, and the right target. Let's say we made a diagnosis of coronary microvascular disease in a patient in whom the resistances and the flow is actually normal, and therefore there is nothing to expect from these devices. And that's the reason why there is an unmet need for very acute, very precise diagnostic means.
Excellent.
And yeah, along the same, I have another question for you. One of the mechanisms of ischemia in this patient is massive subendocardial ischemia. This has been demonstrated in some patients very nicely with CMR. Non-invasive stuff, with non-invasive stuff. Yes, believe it. Well, one of the mechanisms, and I look to you, Tim, isn't that correct that in some patients these devices are supposed to redistribute the flow from epi to endo? Is that correct? Are there arguments in this direction?
Yeah, I think you're correct, Bernard, to state this. There's data coming mainly from the obstructive coronary artery disease, where they really document that the benefit of putting the reducer device is due to the redistribution of blood to the endocardium. What is important also, if you look into the validation studies that have been performed, is that they're most likely in the microvascular situation in patients with coronary microvascular dysfunction. It is much more the increase in pressure that leads to microvascular recruitment across the microcirculatory network that improves blood flow to the heart. So this redistribution is one aspect, so it improves endocardial blood flow in these patients, but particularly in patients with coronary microvascular dysfunction, this increase in pressure, microvascular recruitment is the mechanism of action leading to the improvement in symptoms.
Maybe I'll finish up with just one more word about alternative causes of angina in patients who get vasospastic testing and have severe epicardial spasm. This is not a device that you would recommend implanting in a patient like that. Is that correct?
At this moment, in patients with dominant vasospasm as the origin of their complaints, we do not have any evidence supporting implantation of the device. So we really target patients with coronary microvascular dysfunction. Whether there's concomitant spasm is a different story. Right. Then you can still target the coronary microvascular dysfunction. But if there's solitary coronary spasm, then I don't think at this moment we have enough evidence to put these kind of devices.
Great. We're going to move on. Thanks so much, Tim. All right, our final speaker is Alexandra Lansky, who's going to speak to us about the exciting clinical pathway and the SERRA family of studies that are going to be studying this in a very rigorous way.
Okay, in 4 minutes or less, I'm going to walk you through the, okay, great. So I'm going to walk you through the early feasibility study and give you a little bit of background here, my conflicts. So as we've discussed, we're going to be testing this device in the early feasibility in symptomatic patients with microvascular dysfunction. Here are two principal investigators, Dr. Tim van der Hoff and Samit Shah, who I believe is online. We've talked about the symptoms. This is a patient population with high symptom burden. If you take a look at the SAQ scores of patients with microvascular dysfunction, they're actually worse than patients with obstructive coronary disease. And as you heard, the symptoms are not always exertional related. They really can happen at rest, impact quality of life, recurrent admissions, hospitalizations, etc. So prognosis is not great in this patient population. I want to summarize for you the first in human. This was compassionate use cases in 12 patients. You can see the implantation success was 11 out of the 12. There was one patient that had inappropriate anatomy for the device. And if you take a look at device-related peri-procedural complications, there were none. There was no MACE, no deaths. There was one peri-procedural complication that was not related to the device. That was due to a wire perforation in a case of intravascular ultrasound after the device was implanted. As mentioned earlier, there's early and sustained benefit. This is looking at the SAQ scores. You can see at 30 days, 3 months, and 6 months, SAQ scores actually improve over time and really are maintained and are much improved compared to baseline. And again, in 3 patients here, you can see the improvements in coronary flow reserve. So here's the feasibility study. In terms of the design, it's a prospective, single-arm, international, multi-center early feasibility study aiming to enroll 30 patients. Key inclusion criteria are going to be an abnormal CFR, less than 2.5, based on bolus or continuous thermodilution. Patients are going to be symptomatic, refractory to optimal medical therapy. We're going to be using the Orbiter app for 2 weeks prior to implantation to document symptoms. Key exclusion, you can see here, are patients with obstructive coronary disease and patients with advanced heart failure. In terms of the endpoints, so procedural success is going to be successful implantation of the device without adverse events. We're going to be looking at safety, which is going to be a composite of cardiac death, pericardial effusion, tamponade, or device embolization. And looking here at secondary endpoints, symptom improvement, again, using the Orbiter app, which is going to be addressing some of the questions that were raised, looking at symptoms on a daily basis, as well as some other patient-related outcomes, SAQ scores, KCCQ, etc. Other secondary endpoints, there's going to be repeat hemodynamics performed at 6 months, looking at the change from baseline of all the metrics that we have been discussing, and again, looking at safety outcomes serially out to 12 months. So here's the flow chart. Basically, patients are going to be screened for all the inclusion-exclusion criteria. They're going to be consented, and once consented, all the baseline information in terms of symptoms, daily angina reports based on Orbiter, the SAQ scores, etc., detailed medications, and a PET scan are going to be done. All this information is going to be reviewed by a screening review committee, and then if the patient is a candidate, we'll go to the procedure where invasive hemodynamics are going to be done or repeated or confirmed, and then the reducer device will be implanted. Patients are then going to be followed for repeat invasive hemodynamics at 6 months, a PET scan performed at 6 months, and then again, the Orbiter daily angina symptoms are going to be repeated all the way out to 6 months. And again, the PRO is done at 1, 3, 6, and 12 months. So there in 4 minutes, these are my key takeaways. I think the SERRA-I is really addressing an unmet clinical need, as we've discussed. And it's really putting the interventional cardiologist, I think, front and center in the diagnosis and treatment of INOCA patients. Microvascular dysfunction, as we've talked about, is common. It's about 1/3 of patients presenting to the cathlab with INOCA. There's a very high symptom burden, poor prognosis, limited therapeutic options beyond medical therapy currently. And the SERRA-I is really designed to evaluate the safety, feasibility, and performance of the device, and also to benchmark measures of efficacy for the pivotal SERRA-II trial. So we're going to be looking at both objective and subjective outcomes. Thank you.
Fantastic. We have a question. Yeah, microphone.
The inclusion criteria is low CFR. But are you going to include patients with also low IMR, functional microvascular dysfunction, or only structural?
I'm going to turn to our PI.
We will include both. So the entry criterion is reduced coronary flow reserve measured by means of the absolute coronary, the absolute continuous term dilution technique. So we have absolute coronary flow reserve.
Yeah, the enrollment is independent from the AMR value. The MR is not a criterion. We will collect
We're going to do absolute coronary blood flow in all patients, before and after.
Yes.
Right.
By the way, by continuous thermal dilution, there is no means of measuring IMR. You measure absolute microvascular resistance.
Yeah, but on the slide there was IMR. That's why I questioned that.
So for completeness in this early feasibility study, we will do both. So we will do bolus thermal dilution, continuous thermal dilution, as well as a PET perfusion scan to obtain as much as information as possible. But the entry criterion and also the improvement will be assessed using continuous thermal dilution.
Thank you, Tim.
Any other questions? Oh, yes. Yeah. Please, go ahead.
Go ahead.
Just a quick one. You said that your DAPT regimen is 6 months after, like, implanting the reducer. What if the patient on DOAC?
In case of DOAC, the patient can be left only with DOAC, like we do with PCI. So you don't need antiplatel agent. You need only when you have to discontinue the DOAC in the periprocedural time, and then you can start the you can leave the patient only in anticoagulant therapy. Yeah.
There is a quick one from the chat, and Dr. Samit sent it over for Francesco, I guess. What about femoral access? I know it's not related, but I mean, it's a very practical question.
Femoral access is not a good access for this kind of procedure because because the origin of the ostium of the coronary sinus goes from up to down. So if you go femoral, we are completely not coaxial. And if you want to go from the femoral, you need a larger catheter, a steerable catheter. We can solve everything going very easily from the jugular vein.
I have one comment which I think will sum up almost every talk that was given here, and we can address it to Alexandra or to Bernard. It really is about the volume of microvascular patients that are out there and the fact that we have already identified so many of these patients in our clinics, and they are waiting for us to provide something to give them some relief. And it does give us some hope that we will enroll much more quickly than perhaps in a trial that's looking at no-option PCI patients where it's a little bit more difficult to identify the patients. So maybe Alex or Tim or Francesco can say something about the number of patients you have and how easy it is to identify them as potential enrollees in the clinical study.
So I think coming from the Netherlands, where we have an extensive registry of patients that are in there, and now also with the publicity around starting this new study, actually patients come to us for this therapy. So we don't need to go out and find patients. Patients come to us because they know that there's a new therapy in town.
Yeah, equally on at our site, we have a referral center. We have many patients, and we don't have any treatment options. So for those refractory patients that really qualify for the study, I think it's going to be easy to pre-select them and enroll them. So it's not really a sort of an ad hoc sort of patient showing at your front door.
Exactly. Perfect. Well, I think we've run over a little bit, but I want to thank our amazing panel and thank the audience for coming and spending time with us.